Care of the Hospitalized Child, Module 5. Children are often too young to understand what is happening, and they're afraid to ask questions. Anxiety, stress, and fear of the unknown are common reactions to hospital stays. In addition, they might pick up on fears of the family members, which would hinder the child's progress. Risk factors for stress is what's causing them to be ill. Treatment, guilt about illness, past experiences, disruption in their family life, a threat to long-term health, cultural or religious influences, coping methods, and financial impact. The child's developmental level plays an important role. Child life programs can help make hospitalization less threatening, and under the direction of child life specialists with a background in psychology and early development, they work with the rest of the healthcare team to meet those developmental, emotional, and intellectual needs. It also helps with the child being well prepared, and that will help ease their stress. Early childhood education about hospitals allows children to attend open house programs for healthy children at local hospitals. It also encourages families to help children develop positive attitudes about hospitals and avoid those negative attitudes. Children need to know more than just a place where mommies go to get babies or someone dies. No, that's not just what hospitals are. So the pediatric unit atmosphere, many hospitals have created a friendly, warm surrounding for kids. The furniture is attractive, it's appropriate in size, and is designed with safety in mind. And the staff members often wear colorful uniforms. And the kids have colorful printed gowns and pajamas. They have treatment rooms available, playroom or play areas available. The family caregivers are encouraged to visit as frequently as possible, but in some places, they even encourage family members to stay. Family members can be involved in much of the care, and they try and get the kids as involved as possible. Most units try to make nursing assignments, so the same nurse is going to be with the same child as much as possible. They need to plan meals to include favorite foods as much as possible. And meals should not be served in bed if at all possible. With PICUs, the pediatric intensive care units, this admission can be overwhelming for everyone. The equipment, the lights, the atmosphere can be very frightening, and visitation may be restricted. So make sure you're giving family members a schedule of visiting hours. We need to provide a special doll or a child's toy that can provide comfort and security to the child. Offer positive reinforcements and encourage the caregiver to touch and talk to the child and comfort them as much as possible. Safety is an essential aspect of pediatric nursing care, and nurses have to have safety in mind at all times. That pediatric environment has to meet all those safety standards. Additional safety considerations will depend on the child's age and development level. So check out box 29.1 in your textbook. Infection control is very important because an ill child can be especially vulnerable to all those pathogens that are around a hospital facility. Microorganisms are spread by contact, whether it's direct or indirect, droplets through coughing, sneezing, and talking, or vehicles such as food, water, blood, or other contaminated products. Airborne, with the particles just being in the air they breathe, or vectors such as mosquitoes and other vermin. And appropriate precautions have to be taken. Each precaution will be tailored to a specific microorganism. The U.S. Centers for Disease Control and Prevention and the Healthcare Infection Control Pediatrics Advisory Committee have published guidelines for infection prevention and control practices, and you can see those in Appendix A. Standard precautions. You should know this, but let's review. They apply to blood, all body fluids, secretions, and excretions, except sweat, non-intact skin, and mucous membranes, and they're intended to reduce the risk of transmission of those microorganisms from any recognized or unrecognized sources of infection. So transmission-based precautions, we are always going to use standard precautions. If we have documented or suspected, types will be contact, droplet, or airborne. If the child has a known infection, they are often highly infectious. So it's important to implement procedures to prevent the spread of infection, ensuring that family members understand and also follow these guidelines. Address potential feelings of isolation, loneliness, and anxiety, and depression in the child. Make sure that you continue to promote age-appropriate development and reinforce teaching about these transmission-based precautions. But remember, hand washing and hand hygiene is the cornerstone of all infection control. Wash your hands or use the alcohol-based hand disinfectant conscientiously between each client, even when gloves are worn for a procedure. So it's also important for the family caregivers to participate. When we separate family, it can have damaging effects. Stages of the response to separation can be protest. The child cries, refuses to be comforted by others, or is constantly looking for that primary caregiver. Despair. Now they've given up. They become apathetic or listless. Then they begin to deny. This begins with the child taking an interest in their surroundings, appearing to accept the situation. But when the family shows up, the child turns away and they show signs of distrust and rejection. They might feel abandoned, and it might take the child time to accept the family member again. Rooming in facilities are available at some facilities, and it minimizes the separation anxiety and depression while providing measures of security for the child, and it allows the caregiver to participate more in the care. Also, allowing siblings to visit can help siblings understand the situation. It's important to monitor the caregiver's needs, encouraging them to take breaks, to leave for meals, or go home for a shower and rest. We can always give the child a personal possession for the child to take care of until the caregiver returns. Don't expect the caregiver to assist in the child's care, although many times they do prefer to, which is okay if they want to. Just don't expect it. Hospitalization hampers normal patterns of living. These infants do not understand pain, they don't understand discomfort, and they don't understand limited normal activity. The infant can become apathetic and they can cease to learn. In addition to nursing care, touching, rocking, and cuddling are essential for the hospitalized infant. Age-appropriate sensory stimulation and play within the constraints of the infant's condition are important. When an infant is hospitalized, the family caregiver can give the child stimulation, care, and attention by feeding, holding, or diapering the infant. With the toddler, keep in mind the toddler's developmental tasks and needs and understand this is a very frightening time for the toddler. They have an inability to communicate well. They may have discomfort from pain and problems with separation from family. There's a presence of unfamiliar people and surroundings. Physical restraints might be necessary. They are uncomfortable or frightening procedures, which just increases the turmoil. So it's important to maintain routines, conduct social assessments to determine home routines, and try to continue them as much as possible. And include those in the nursing care plan. That nursing care plan should provide opportunities for toddler independence. Their separation anxiety is high, and the nurse may become a surrogate parent. Allow security of lovely. Use terms that the toddler is going to understand. Special considerations. We still need to maintain control and promote safety and help establish that toddler's sense of security. At the same time, we allow development to continue. Avoid putting the toddler back in diapers when they're on the unit, and make sure we provide potty chairs. Explain what's going on and what you expect from the toddler and what the toddler can expect from you. Eating habits might be a problem, and safety promotion might be challenging. With the preschooler, keep in mind the preschooler's developmental tasks and needs. Play is an effective way to let children act out their anxieties and learn what to expect from the hospital situation. Explain procedures in words that are appropriate for the child's age. These kids might revert to bedwetting. And as with toddlers, hospital routines should follow the home routines as closely as possible. And allow the child to participate in their care. With the school-age child, they have an increased understanding of their bodies, a continued curiosity about how things work, and development of concrete thinking. All of this is going to help the school-age child understand and better accept healthcare experiences. But the nurse needs to understand how concepts about birth, death, the body, health, and illness change between the ages of 6 and 10 years. So check out the table at 26-3. Make sure you explain all the procedures, show them all the equipment and materials to be used, outlining realistic expectations, and answer all their questions. These kids also need privacy and may not want physical contact with adults. They might also be uncomfortable having someone of a different gender bathing them. The child might also regress and try to prevent that regression. Reassure the family. Make sure that you're following discipline and rules. Opportunities for interaction with their peers, learning situation, doing crafts and projects can help the school-age child through this period. With the adolescent, hospitalizations are usually related to major health problems. So now they have to cope with the stress of hospitalization, possible dramatic alterations in their body image, partial or total inability to conform to their peer group norms, and this can also interrupt their search for their identity. The adolescent fears loss of control and loss of privacy, so it's important to provide opportunities to make choices and protect privacy. Be aware that they might be angry and they might refuse to cooperate. Again, interview the adolescent and the family caregiver separately. Thoroughly explore their developmental level. Listen carefully with empathy to all of their concerns. And encourage maximum participation in self-care. Provide sufficient information to make participation possible. Make sure they know the rules of the unit and provide recreation areas. Access to the telephone, computer, email are important, and allow them to wear their own clothes, to style their hair, and to wear makeup. So, question. Some hospital pediatric units have a program to make hospitalization less frightening for both children and their parents. This program is overseen by whom? This is the child life specialist. Admissions to the hospital can be frightening experiences. We need to explain to the child where they're going and why, and answer their questions truthfully. When they arrive, they should be greeted in a warm and friendly manner. Take the child to their room or a room that's set aside for the admission process. Then orient the family caregiver and the child to the child's room, the nursing unit, and regulations. So check out box 29 too. With planned admissions, we might be able to do pre-admission preparation to help make the experience less threatening. This would include an open house or pre-admission tour, which would allow the child and family caregiver to see the area. And they might also be given some of those bling or swag or trinkets, etc., such as special coloring books. Kids might be hesitant to ask questions. Make sure you always use terminology that the child will understand. Be honest and specific. This will help establish trust. Be sensitive to cultural and language differences and offer activities similar to what the child will experience in the hospital. With emergency admission, there's little time to introduce the child and family caregiver to the facility and to the procedure, but physical needs are going to assume priority over emotional needs. The child might be angry that the family caregiver is not stopping invasive and hurtful procedures. Allow the caregiver to stay with the child whenever possible. ED nurses need to be sensitive to the child and the family and recognize cognitive levels and how it affects the child's reactions. Always explain those procedures in a caring, calm manner to reassure both the child and the family. So with the admission interview, that should be conducted as soon as possible after admission. The ID bracelet is placed on the child's wrist and an allergy bracelet if necessary. Try to determine past experiences with hospitals and healthcare providers, and determine how much the child and family understands about the child's condition and expectations of the hospitalization. What support systems are going to be available after discharge, and any concerns of the family caregiver or child. With the admission physical exam, after orientation, the family caregiver might undress the child. Procedure may be familiar once again from previous visits, and the caregiver can stay with the child during the physical exam. Discharge planning begins early in the hospital experience. It's important to determine the level of understanding of the child and the family caregiver, the abilities that um, provides opportunities to learn about the child's condition and their care that might be necessary following discharge. The child might be given information, uh, also depends on their age and their cognitive level. We might need to arrange for the home health nurse to assist for a period of time after discharge. The return home can be a really difficult period of adjustment for the entire family. Various responses will depend on the age of the child. Discipline should continue even after the child goes home. It needs to be firm, loving, and consistent. And we need to encourage families to avoid making the child the center of the attention, even with the illness. So, question. There's several components to the admission interview. Which is one of them? Determining what the child and caregiver understand about the reason for hospitalization. So a child that has to undergo surgery, this could be really frightening. So proper preparation will help older children and adolescents understand the need for surgery and what they plan to accomplish. Outpatient surgery facilities are often utilized for minor surgical procedures. This will permit the client to return home the same day of surgery. The child requires compassionate and thorough preoperative and postoperative care. So preoperatively, provide that client and family teaching. Determine what they know and understand, the age of the individual, the level of development, their capability of learning, and any misunderstandings. Explain what preparations for surgery are required, how it's going to fix the child, and how the child's going to feel after surgery. Encourage questions. Prepare them for any preoperative tests and procedures. Understand the child might consider the process as punishment for something they did, and they might have a lot of fears. Therapeutic play is very useful for the younger child. The older child or adolescent might have a greater interest and they might desire specific information regarding the surgery. So describe the process in terms that all kids are going to understand, such as special sleep for the anesthesia and wake-up room for PACU. Describe what they should see when they wake up. Prepare them for that postoperative pain and practice coughing and deep breathing before surgery if you can. Minimize separation from family as much as possible. Skin preparation will depend on the type of surgery and may include a tub bath, shower, special cleaning, and inspection of the operative site. Fingernails and toenails will be trimmed as needed, and special antiseptic solution might be used to cleanse the operative site. With gastrointestinal and urinary systems, they may need a cleansing enema the night before surgery. They will be NPO for a period of 4 to 12 hours prior to surgery, depending on their age and procedure. The younger they are, the less time they can go without anything to eat or drink. So they might have an IV fluid initiation order. Make sure that you count and record the number of teeth per hospital policy. Urinary catheterization might be done before surgery, but is usually done in the operating room. It might be removed immediately or left in place as needed. If the child is not catheterized before surgery, we will encourage them to void before they are given preoperative medications. And those preoperative medications will depend on the healthcare provider's order. They may get a sedative about 1.5 to 2 hours before surgery, or analgesics or anticholinergic mixtures immediately before going into the operating room. We encourage you to bring the medication to the child's room when it's time for them to take it. And if the facility permits it, family caregivers should accompany the child to the operating room and wait until they're anesthetized, or the nurse will go and then introduce the child to the OR staff. As far as postoperative care, they're going to receive care in PACU or the surgical ICU. They prepare the room on the pediatric unit with the appropriate equipment, and the focus will be careful observation for any signs or symptoms of complications, such as shock, hemorrhage, or respiratory distress. Monitor the vital signs, keep the child warm, pay attention to those dressings, IVs, urinary catheters, etc., and always document per facility orders, or policies. Make sure you note the first postoperative voiding and notify the healthcare provider if anuria persists longer than 6 hours in the child. Ice chips or clear liquids might be given. Repositioning, coughing, deep breathing will be done. Pain management is really important. Infants and young children are unable to adequately express themselves, so we look at indicators of pain such as their facial expressions, changes in behavior, physiologic changes such as their vital signs, oxygen saturation changes, palms are sweating, pupils are dilated, skin is moist and flushed, or a loss of appetite. The toddler might point to an area and use simple words. Preschoolers can indicate where the pain is and describe with the use of the face tools. School age and adolescents are usually able to indicate the location, type, and intensity of pain. Pain medication can be administered through oral, IM, IV, the patient-controlled analgesia. We do try to avoid the IM injections if possible. These kids might avoid admitting to pain if they think they're going to get a shot because the shots hurt. We need to monitor vital signs and level of consciousness frequently. Consider non-pharmacologic comfort measures if at all possible, such as position changes, massage, distraction, heat, cold, play, soothing touch, talking, coddling, affection. That activity has to be appropriate for the child's age, their level of development, and their personal interests. We need to observe their surgical dressings for signs of drainage or hemorrhage and reinforce or change the dressings per orders. Note the amount of drainage and color when dressings are changed. Follow facility policies and healthcare providers' orders when changing dressings and the types of supplies that are used. Explain the procedure before starting and inform the child if it might hurt before starting. Make sure that you praise for good behavior. With teaching, postoperative reinforcement is necessary. Repeat explanation and instructions as needed. Discuss those dressings or tubes or restraints. Inform the family caregiver how they can help and if there are any restrictions, what they can expect. Reassure the child that their insides are not going to fall out when the staples or sutures come out, and have family caregivers demonstrate any procedures they might need to do once the child is discharged. Question. Jimmy is 6 years old. He's been admitted to your unit for gastric surgery the following day, and the surgeon has ordered a preoperative enema to be given. When would you expect to give this enema? This will be done the evening before surgery. So the hospital play program. You know, play is the business of children. It's the principal way that they learn, they grow, they develop, and act out their feelings and problems. It helps children come to terms with the hurt, the anxieties, and separation. They have the opportunity to express frustrations, hostilities, and aggressions through play without the fear of being scolded or corrected. Children should not be allowed to harm themselves or others. When behavior correction is needed, it is important to make clear the child's action, not the child, is being disapproved. So this hospital play environment should be organized and well planned, and this is important to their overall care. It needs to be large enough to accommodate cribs or wheelchairs, IV poles, or children that might be in a cast. Provide a variety of play materials. It's usually unstructured and the child makes the choices. But there needs to be a separate area for the older children and adolescents. This is where they will gather to talk, play pool or ping pong, watch television or a movie, or use a computer. But if a child has to stay in their room, they do need age-appropriate activities available. If they're unable to go to the playroom, be creative in providing those play opportunities. Take materials to them and have someone available to give support and attention. Always observe infection control precautions, though, if the child is in isolation. Therapeutic play. Well, play therapy. This is a technique of psychoanalysis that's used to uncover a disturbed child's underlying thoughts, their feelings, and their motivations, and it helps us understand them better. But therapeutic play is a technique that's used to help the child have a better understanding of what's going to be happening to them. So, we can give them materials and encourage them to start an IV on a stuffed animal or a doll. It helps the child express their fears, their feelings, and their concerns. And that play leader needs to be very alert to the needs of the child. But other children might be the best ones to provide incentive to play. Again, with the play material, has to be safety first. Toys and equipment need to be inspected regularly to make sure they're not broken or pieces coming off. Provide hospital equipment to allow the child to act out their feelings. Dolls and puppets can be dressed to represent certain people. Simulated hospitals can also serve as an educational purpose. Useful play materials might include clay, paint, markers, crayons, stamps, stickers, sand art, cutout books, construction paper, puzzles, building sets, board games, books, etc. Check out Table 29.1. So true or false? Allowing a child to play can help identify issues which may need to be addressed. This is true. And now for the post-test.